Thank you, Dr. Ahmed, for the nice introduction, and thank you, SSBMT, for inviting me to be presenter. Yes, I know it is a difficult subject and very sensitive subject. I'd like to thank also Dr. Ihab for his presentation. He make it easy for me, so I'll overcome some of the slides. This is my objective. So, both sickle cell disease and thalassemia, it's chronic disease with lifelong accumulating complications, multiple system, serious complications that will affect the health of patients from different aspects, from the disease and from the treatment also. Quality of life of both disease is, if you survey these patients, it is poor. And in this survey, for both and adult, the quality of life of patients with sickle cell disease and thalassemia is almost close to patients with cancer. Survival with improvement in prophylactic therapies, transfusions, but still, as you see in these curves, patients with sickle cell disease, they live shorter than healthy patients. And in the left side there, or your right side there, the median survival between 50 to 54 years for sickle cell disease, which is significantly short survival, unfortunately. The cost of therapy in this study, it was done from Canada, large patient, 10,000 sickle cell disease. They compared the cost of therapy to another 10,000 other groups of patients with different diseases between 2016 to 2022, and at all aspects of treatment, admissions, medications, treatment of complications, as you see in the table for both adult and pediatric, the cost of care of patients with sickle cell disease is much higher than other patients. The lifetime medical cost, this also from North America, study done. The cost of caring for one patient is almost 1.6 million US dollar, the lifetime cost, which is almost equal maybe to 7 million Saudi riyal. In Saudi Arabia, I found this very interesting recent publication from the Eastern Province, which is showing they did very nice economic calculation to calculate the cost of therapy related to societal cost, total healthcare cost, and the total productivity or indirect cost. So by Saudi riyal, if you calculate all the three domains, it's 18 million per one patient for the lifetime of the patient. So the North America was 7 million, here is 18 million, there is a big gap. But the care of these patients, we know it's very expensive because we are dealing with serious complications and treating patients that maybe at one point they reach in this stage of life. So usually I put this slide, the first slide, but I put it here because the cost now and the large number of the patients. So the burden of treating patients with sickle cell disease in the country is huge. And the Ministry of Health and all health institutions. So treating these patients with curative treatment, I think it is a very important strategic goals for our country that we need to work on. The other point, the current therapies, there are a lot of limitations. They are not like hydroxyurea. It's a very good drug, but doesn't work for all patients. And it has also side effects, unfortunately. Chronic transfusion, the risk of chronic transfusions, the iron overload, and allogenic transplant is a very good type of treatment, but also there is the limitations, donor, GVHD, transplant-related mortality. This has been presented by Dr. Ihab. The gene therapy, it is autologous transplant. At the end, the patient will get conditioning regimen. It's not like the hemophilia gene therapy, just one infusion. No, here you will collect the cells and cryopreserve it, but compared to autologous transplant for myeloma or lymphoma, there will be some modification in the cells before we infuse it back to the patient. And these are the strategies for gene addition or editing that was presented by Dr. Ihab. The gene addition, we use the lentivirus. It is a complex type of procedure. So we estimate it will be of high cost. And the CRISPR-Cas also was shown by Dr. Ihab. So, but really we don't know what is the cost when we send the lab cells to the lab or to the company. What is the cost of the gene modification, gene editing? Does it really reach that high level of price that we pay for this type of treatment? But it is a very sophisticated type of modifications. So the patient journey, very important here, as shown by Dr. Ihab, it's 6 steps: patient identification, pre-mobilization, mobilization, gene editing, conditioning, and follow-up. So what we will pay to the company, we will pay only this part. From 2 to 3 million US dollar, we pay this one. While all of these steps, it's still additional cost on the hospital that we don't count. So we have to take this also in consideration. These are the trials for the gene, for the TDT. Dr. Ihab mentioned about PT-cell and XSL, and for sickle cell disease, Lovocell, XSL, and the BEAM also is base editing of PCL11A. We don't have the screen here. This was also shown by Dr. Ihab. This is the updated presentation from the last ASH 2025. For the XSL for sickle cell disease, the primary endpoint previously it was 94%. With long follow-up, you see it dropped to 91%. So it's still durable, but we need a longer follow-up. Is it going to drop further more than this? We don't know. Even the secondary endpoint, 100%, but it dropped to 98%. And for the transfusion-independent thalassemia, it's 98% of the patient achieved free transfusion at 1 year. Okay, so this slide is also important. It's showing that this type of treatment is durable. So far with this amount of follow-up for like the maximum like 54 months, we are maintaining the level of the hemoglobin and the hemoglobin F. And not like the hemophilia gene therapy when you see drop in the level of factor 8 or factor 9 with time, but here we are seeing maintenance of the response, which is very important aspect in regard to this type of treatment. And by checking the gene editing, also it's maintained over time. And quality of life is a very important aspect that is add on to the benefit of this treatment. The toxicity, it's mainly limited to the chemotherapy, which is busulfan. So if we find a gene therapy without conditioning, that will be even non-toxic, even type of treatment. These are the inclusions for sickle cell disease, basically age 12 and above in the Saudi FDA, but in our hospital we cap it to 35. Similar to the study design, basically patient with recurrent VOCs or acute chest syndrome. But you see a very long list of exclusion criteria. We receive many referrals, but many of them, they will have one of these exclusion criteria as red flags to exclude them from the gene therapy. For transfusion-dependent thalassemia, a minimum 10 transfusions per year or 100 ml per kg per year. So at a level of institution or operationally, you need authorized treatment center. It's not a treatment that can be given in every hospital. There are many important services that need to be available to administer this treatment to make it safe for the administration. GMP facility, if you are going to do the gene editing or gene addition in your lab, multidisciplinary team. It's very important to have all services, infectious, pulmonary, because they will have a role in preparing these patients and follow-up post-transplant manufacturing timeline, ICU and ward capacity, long-term follow-up, and registries also important. So the economic reality, here we have the gene therapy involve a high single event cost of approximately $2 to $3 million per patient, creating significant short-term budget impact. This cost must be interpreted in contrast to the cumulative lifetime expenses of chronic disease management. The primary economic challenge here of gene therapy is the concentration of lifetime treatment cost into a single upfront payment. While long-term value may be favorable, short-term affordability remains a major health system constraint. So you are comparing one-time treatment that will have durable and free of other complications to a conventional type of treatment with lifelong complications and treatment. So you are providing here a durable, if you provide durable genetic correction, then the patient will be transfusion free and chelation free. Then fewer hospital and ICU admission, reduced the long-term healthcare utilization, and improved quality of life and societal productivity. Yes, we have to take these in consideration when we think about the cost of the treatment, to say it is expensive or it's not expensive and it has good value. So talking about cost versus value, the cost reflects the price paid at a single point in time, while value reflects the clinical benefit achieved over the patient's lifetime. In gene therapy, value is determined by the durability of response, magnitude of clinical outcome, and quality adjusted life years gained rather than upfront price alone. So a high-cost therapy may still be of high value if it prevents years of morbidity, eliminates recurrent admissions, improves survival, and delay functions. And I think this can be applied to this type of treatment, the gene therapy. While a lower-cost therapy can be low value, like if you think about the current available medications for sickle cell disease or thalassemia. It requires lifelong treatment, accumulates complications despite receiving the treatment, and fails to change disease trajectory. Also, there is a big challenge of health system that we need to take in consideration: the budget allocation, reimbursement model, outcome-based payment, and long-term liability. The challenge for health systems is not whether gene therapy works, but how to responsibly pay for it, monitor it, and remain accountable for outcomes over decades. The clinical reality today, this is not the first-line treatment. We have to realize that. As Dr. Rehab mentioned, not all patients need gene therapy or transplant. Some of these patients, they have very mild phenotype, so we are not applying this therapy for them. It's best to be delivered in expert centers that do a lot of transplants. Then they use this as based on their experience, because you will have less risk of complication, and you know how to manage complication because you are already doing this for transplant. Now, is it competing with transplant or complementing transplant? I think it is complementing transplant. We are lucky to have both modalities in our country for our patients because the number of patients is huge. You cannot do transplant for all patients, and you cannot do gene therapy for all patients. Not all patients are eligible for transplant, and not all patients are eligible for gene therapy. So, and we know from, at least from our experience, the transplant is very good and benefit a lot of patients. So it is complementing the allogenic transplant. However, careful patient selection is very important. Optimal outcome in younger patients with preserved organ function requires assessment of medical, psychological, and logistical readiness. And this is what we do before we take patient into transplant. Future directions: less toxic conditioning. And currently there are conditioning non-chemotherapy, like antibody-based, where you have antibody directed to the stem cells in the bone marrow, and that will not cause toxicity to the body. So this will be like game-changing. In vivo gene editing, also like the hemophilia gene therapy, you just infuse the gene, the product, it will go and it will do the in vivo gene editing, and here you don't need to give chemotherapy. And this can be applicable to those patients who are excluded from current gene therapy because they cannot receive Peselvan. Improved access, expansion of qualified treatment centers, and this is already done. Development of regional and national referral network, streamline manufacturing and scheduling pathway, cost reduction over time, manufacturing efficiencies with the scale, competition across platforms, potential for innovative payment models, and I'm sure there are multiple companies that will come, and the price of the currently available gene therapy also will go down. So take-home message, gene therapy is clinically transformative, as mentioned by Dr. Ihab, can achieve sustained disease-controlled and functional cure in selected patients. It's still complex and resource-intensive, requires transplant-level infrastructure, prolonged hospitalization, and specialized teams. Gene therapy is not replacing existing curative strategy, it is expanding the curative landscape for carefully selected patients. And this is what we saw in our setting. It's become like additional for some patients. Appropriate patient selection remains the strongest determinant of success. Wider adoption will depend on safety, scalability, and sustainability. Thank you very much.